But please try to keep your mics muted. You can choose to stay on camera or off camera. That's up to you. But just I ask if you could please try to stay muted throughout the presentation. If you do have questions, just throw them into the chat. I will be monitoring that, and we will try to get to all the questions at the end of the presentation. So if you have any questions for me or for anything else, just throw whatever you need into the chat and we'll get started. So Dr. Abell, I will mute myself and you can get ready to go.
Okay, good. I hope everybody can hear me. I'm going to switch to full mode here. Here we go. All right. Well, it's a pleasure to be here. I'm Tom Abell, who some of you know. I'm currently at the University of Louisville. I've been in the Mid-South for almost 40 years since I left Rochester, Minnesota in the 80s. And during that time, I was working as a primary care physician to support myself while I trained in GI motility as a research fellow. So I've had many former lives. My main funding is the NIH Gastroparesis Research Consortium, which I've been part of for almost 20 years. And a lot of what I'm going to talk about is influenced heavily by them. We also have 2 other NIH grants actively right now relating to gastroparesis.
Okay, good. Then I can hear you too.
Investigator for some, these are either recent or current, consultant, reviewer for Up to Date, which I recommend highly. I use it a lot myself. Section editor for a couple journals, and I have some intellectual property that's not active right now. And some of the items I mentioned will be off-label. I'm going to use some trade names, which you don't usually use, but that may be a little easier for people to understand. Okay, I'm going to talk about new approaches to GI motility disorders and some new diagnostic tests. I got 3 new diagnostic tests to talk about and 3 new, relatively new therapeutic options under the categories of diet, drugs, device, disruption, and detoxification. I'll talk a little bit about the FDA, which there are friends at the FDA, but it's been a difficult time for us in motility at the FDA. And we'll have room for questions at the end. And any questions you don't get to, I'll make sure we answer eventually. So I think when we see patients in our clinic, one way or another, and we see some people virtually as well, we try to we realize that many patients are aware of support groups like the one today. We get referrals and records, and we see them and do history and physical, but we do an assessment that includes patient-reported symptoms, nutrition, and quality of life. And we try to also do a social assessment because family and other social support is so important. And then we work on a plan, initiation, and follow-up. So our standard diagnostic tests include endoscopy, imaging, and routine laboratory, but I'm going to talk about some specialized tests, including the EGG that we do, nutrient panels, immune measures, and other laboratory measures, some of which we don't do yet, but we may do in the future. So body surface mapping is one I'll spend a little time on. I talked about it a few months ago, but it's FDA approved, and I'm not commercially related to this, but I did, my group when I was in Mississippi did some of the basic science work that led to this for high resolution EGG, and it's approved actually for patients 12 and above, 12 years old and above, and soon will hopefully be approved for even younger patients than that. We also do, we're very interested in the autonomic nervous system, although it's not widely measured. And I'll show you some slides about body surface mapping. I'll also talk about some pyloric measures, flip functional luminal imaging probe, which we do, and there probably won't be time to talk about full thickness biopsies, but we'll try to talk about maximizing medical management and particularly personal quality of life. So this is talking about Allometry, which is a trade name for the company from New Zealand, and we're very active with them because we have an NIH grant for the last few years. That continuing on, looking at high resolution EGG. In the past, we did single channel electrogastrograms, or we did low resolution EGG for the last 40 years. But this is new. It's as I'll show you, it's a grid of over 60 electrodes on a sort of a abdominal bandage. And there's a little recorder that goes on, and then there's a patient holds a mini iPad that they record their symptoms. So it's unique. It goes on in a standardized manner. Here's a patient who happens to be a female getting it put on, and here's what it looks like when it's put on, and then we sit in a chair. And we like to do it fasting and fed, sort of like a gastric emptying. So it's roughly 4 hours or a little bit longer for our test. Almost exactly is the length of a gastric emptying when you consider the time to eat the meal and get there and get set up. And what one looks at for normals is you get a report. Actually, this goes to the cloud, and we get a report almost instantaneously. We look at a couple metrics, 4 main metrics, but they basically relate to frequency and amplitude. Normal frequency is about 3 per minute, seen here. And there's a rhythm index that also looks at whether this rhythm stays in the normal range or not. So those are a couple metrics as we talk about them. There's amplitude. There's a fasting amplitude. We measure this in microvolts. It's BMI adjusted. And then we look at the amplitude ratio between fasting and fed. You see the frequency and amplitude both go up when you eat a meal for normal controls anyway. So these 4 metrics give us an idea, and we've standardized this in numerous normal patients, both here in the United States and in New Zealand, where this device is made. And you get a normal propagation. This is I usually have a video showing the stomach electrically contracting upper, mid, lower stomach. And usually you see, again, here's fasting in the meal and then increase in frequency. And amplitude, here's normal, increase in amplitude. So we know what normal propagation looks like, and also there's some additional metrics that are going to be FDA approved too, to look at degree of propagation as we measure it throughout the GI tract, starting with the stomach. These are examples of patients, and we have different groups that we call phenotypes. This is a neuromuscular profile. You see the difference before with 3 per minute normal, and in this case, not 3 per minute normal. And amplitude is here, but you see it doesn't really change much with the meal. So this would be something we would consider neuromuscular damage, and we get the metrics printed out here, so we know what it looks like for a given patient. Another one sample report is this one, which we call sensomotor. There is relatively normal frequency here, and actually relatively normal amplitude that increases with the meal. But look at the symptom burden here, which I didn't show before. The symptom burden here in this case increases with the meal. And the example here, the symptom burden is kind of continuous. And we could talk about visceral hypersensitivity, which is something that we talk about that's poorly understood, but it's one of our phenotypes. And here's the continuous. Again, starts out with the normal frequency and then sort of disappears. Amplitude goes up, but you see the symptom burden really is the same throughout. This part's done by the recording on the grid on the stomach, and this is done on the little iPad. So we think about things that may be inflammation related or centrally mediated disorders. And we have a large National Institute of Health study going on now for probably about 3 more years, trying to validate this for clinical use, but it is already FDA approved and available. I'm going to go on to another diagnostic test, and that relates to gut transit, which we did. I use trade names here. We did use the Smart Pill before, but it was taken off the market not because there were any problems with it, but the manufacturer didn't feel it met their needs. So there've been actually 2 more things that are now approved by FDA. One is very similar to the Smart Pill. I haven't used it yet, but it sounds like a nice thing. And this other one's called the Atmo capsule, which I'll talk about. It's a valid method for transit times, and it uses actually fermentation of the gut, looking at oxygen and CO2. And we and others did a study looking at people taking a smart pill and the Atmo together, which is quite an episode of swallowing. Measured these tandem data and looked at receiver operating characteristic curves, which is a standard way to look at data. And we had 346 patients, 85 controls, 61 with suspected dysmotility, and others were included. This is data that's going to be presented at the American Neurogastroenterology and Motility Society in a couple of weeks, which most of you probably won't go to because it isn't a meeting that primarily is for patients, but it's we basically looked at how often people had delayed transit, and as we often see, gastric emptying about a quarter of the patients, small bowel transit almost a quarter, colon transit about a quarter, and the whole gut transit almost a quarter again. So they're kind of divided into 4 groups, and we compared various things between the 2 pills, and there were very few differences. So the current diagnostic threshold for identified delayed regional gut transit can be used for the Atmo capsule. So those of you that had the smart pill before, it can be used again with Atmo or the other one that replaces smart pill. And I think that's going to be a nice diagnostic test if you haven't had one, or if you're a patient who has more than gastroparesis with other symptoms, this might be a useful test. So the first test I talked about was the high resolution manometry body surface mapping. Then I talked about these various kinds of pills that can be used for transit, and they can measure many other things in terms of fermentation. But I'm going to talk about something now that's been investigational and still investigational. This is chemoluminescence for antibodies in patients with gastroparetic symptoms. And we've been working on this for 20 years. We did a pilot study, which I'll mostly talk about today, with 18 patients. And we also looked back at some of our previous NIH work and did a larger study. And wanted to see whether these autoantibodies might be present in people with either gastroparesis or functional dyspepsia. We looked at people with the 18, 12 were normal and 8 were high. With this quantum flash, which is their measure. We wanted to see what that meant. We also looked at, which I won't present today, but just so you know, we looked at 43 patients, roughly half and half gastroparesis, functional dyspepsia. And we have a lot more data on the patient. We have autonomics, clinical symptoms, various other assays. We have a couple of large studies that'll come out over the next 2 years about that. And we use statistical software. But if you look at the people that had the quantum flash, 6 were high and 12 were normal. These are various classic antibodies, smooth muscle, Rho60 and SSB. SSB may recognize the name Sjogren's because SSA and SSB are Sjogren's. But for all these, there were either significant, less than 0.5, or borderline differences between high and normal. So this plus the new data that we have makes us think that this may be useful. They correlate with classic antibodies, and we, from other data that I didn't show today, we looked at symptoms, anatomic physiology, and autonomic measures. And again, we hope to get phenotypes looking at patients. When you come in with nausea, vomiting, we hope we can look things like high resolution EGG, these various intelligent pills, and these new antibody tests, try to get a better idea of what's wrong, and thus how do we treat people. So I'm going to stop for a minute and say that's the 3 new diagnostic tests. There's plenty more. And part of what I wanted to say, and perhaps should have said it first, was this, that when you're sick and you're miserable, it's like you wonder sometimes, is anybody doing anything about this to help us? But I want to let you know there's a lot of people very interested in helping patients and their families. So in terms of therapies, I've sort of looked at 6 areas. I've talked about diet, which I'll talk about a little bit today, which unfortunately is, even though it's probably the most important, we know the least about. I'm going to talk about drugs and pharmaceutical options, which unfortunately, again, we're limited what we have available in the US right now. I'm going to talk about bioelectric devices, which is what I spent most of my last 40 years working on, but I'm not going to spend an inordinate amount of time on that. And talk about disruption in endoscopic and surgical means, particularly for disrupting the pyloric sphincter, and talk about detoxification and immune-mediated therapies. And then lastly, but not least, our duration, which I talk about social, family, and other support. And the support groups are like today's group, are crucial. In fact, for some of my colleagues who weren't sure that they wanted to be involved with support groups, we documented and published that if actually somebody's in the support group, they do better, and they actually call the office less because they get help from each other. So hopefully we've convinced everyone that a great idea. So let me go on briefly to some of these. Diet, there's a long history of the best diet for gastroparetic symptom patients. And here I'm including both gastroparesis or delayed emptying and functional dyspepsia, where you have the same symptoms but non-delayed emptying. And I think most of us think and feel that there's a spectrum, like many illnesses, a spectrum of disorders that manifest just in slightly different ways. There are many different diets used. One pattern that our GPCRC realized when we look at frequency questionnaires, which are a validated way to look at this, that carbohydrate intake predominates, which is probably one reason that patients in the past didn't gain weight, but now do gain weight when they have gastroparesis symptoms, because they primarily can tolerate carbohydrates best. Fats are hard to digest, proteins are hard to digest. Carbohydrates can be tolerated, so they get an imbalance. And most of our gastroparesis syndrome patients are either overweight or obese. Now, there are new drugs, of course, for obesity. Unfortunately, some of the new drugs that are wonderful drugs have the side effect of causing essentially gastroparesis-like illness. So for some patients, that's not an option, but I'm hopeful out of what's coming out of all this work with the GLP and GIP drugs that we're going to learn a lot more. Drugs, I'm going to talk a little bit about new drugs, but most of the drugs that we have are in 3 drug classes, either dopamine antagonists, 5-HT3 or 4, 5-HT3 or antagonists, 5-HT4 agonists, and NK1 antagonists. Most of the drugs that are either on the market or investigated regard one of those 3. There are some novel drugs. The issue is right now with the FDA is that the programs remain in flux. As you know, a lot of things with the FDA are in flux. We had a meeting with the FDA, and I know them well and like them very much. We had a meeting with them over a year ago, talking about the fact that no new drugs have been approved for gastroparesis in 40 years since Reglan. Reglan, as you may know, has some long-term problems that are an issue, and it's so much so that it's not recommended that you take it for more than 3 months, although some people do take it intermittently. And the dopamine antagonist domperidone has been available by FDA program for a number of years. I helped set that up with some colleagues many years ago, and about 20 years ago. The problem is that the pharmacy that gets their supplies for that program has lost their supplier. So the FDA has told us, and told us again yesterday, that they're going to discontinue the program, which is a great distress to all of us, and even greater distress to our patients. And we're trying hard to find other manufacturers, either in Asia or in Europe or in the Middle East, that can supply this for the patients, because domperidone is a good drug and doesn't have the side effect problems that regular metoclopramide has. So again, the current status is lots of drugs companies wanting to be involved. What can be done? Well, there's scientific approaches, support groups, political approaches. I'm not averse to saying that if you're having trouble getting a drug, whatever, you can call your congressman or whatever, because the FDA and other organizations, perhaps I shouldn't say this, but they are politically responsive. And I know when I was working on investigational trials, patients sometimes couldn't get in the trial. They would call their congressman or senator when I was living in Mississippi or Tennessee or Arkansas. And at that time, Bill Clinton was president, Al Gore was vice president. They were able to get a hold of somebody. And the next day I had someone from the FDA calling me, wanting to know what they could do to try to help get the patients in. So I'm sure they didn't like to have to do that, but they do respond politically, and perhaps it is the time for more political action. So devices, many devices have been tried for gastroparetic symptoms. One approved device for gastroparesis, that's for drug refractory diabetes and idiopathic gastroparesis. My team in Memphis developed that technique and licensed it and did the first patient in the world. But and I see a lot of those patients. I'm not involved in way commercially with them. But there are other devices in trials. Most have vagal effects, whether it's direct vagal stimulation or indirect vagal stimulation. And this is a source of intense investigation. So I'd like to show a couple things about the one device that's available, but this is going to be off-label. Again, patients with gastroparesis functional dyspepsia have similar symptoms, and people can respond to temporary mucosal stimulation, which we use, and Lowell and other sites use, particularly pediatric sites use it. It's off-label, but we use it in people with the symptoms of gastroparesis, and if they're delayed, they're gastroparesis. If they're not delayed, they're functional dyspepsia. But we use it in both. Again, off-label. We looked at 314 patients, and basically they were mostly idiopathic patients, almost perfectly divided between gastroparesis and functional dyspepsia. And we look at gastric emptying, the standardized test, and standardized PRO scale, 0 to 4 scale, 5-point scale. That's similar to the gastroparesis daily diary. But we also look at foregut and hindgut domains. And we looked at baseline after roughly a week of temporary trial and 1 year. And we used correlations. So baseline, there were little difference between solid and liquid differences, except that, of course, we've defined the gastroparesis is delayed and functional dyspepsia is not delayed. In functional dyspepsia patients, the vomiting and urinary symptoms correlated with mucosal, which was one technique that we use, mucosal EGG, low resolution amplitude, and cutaneous, which we still do, cutaneous EGG frequency. And that's in functional dyspepsia. And in gastroparesis patients, 1 year symptom improvements for some of the symptoms like anorexia, bloating, and abdominal pain were associated with, again, with approximately mucosal amplitude. So again, I think the reason to think that these EGG measures are helpful. I'm not going to go over this a lot. I just want to point to most of these p-values are highly significant. There's one that's borderline on constipation, but you see it affects not only the upper gut, but the lower gut. And people say, I've never heard of that. Well, partially because we and others didn't look at that. And if you ask the patients, indeed, their diarrhea, their frequent urination gets better as these other do. This is the temporary baseline 1 year for gastroparesis and functional dyspepsia. And one other thing I'd like to show you is the gastric emptying, solid emptying, delayed baseline, delayed here, but you see the emptying here becomes 23% from 31 during the trial, and in 1 year it's identical change. Functional dyspepsia belongs a little bit to 10.2. It's almost the same 1 year, 10.6. So people would say, well, I thought that stimulation doesn't affect emptying. Well, it depends how much energy you give. It's like anything. Your car may not get very good mileage when it's idling. When you press on the accelerator and put it in drive, it goes faster. So it's like that with stimulation as well. Let me show one other thing on body surface mapping that I talked about earlier in patients with electrical stimulation. We wanted to look at basically stimulation and body surface mapping, and we this is part of our early on our NIH work. We had a 30-minute baseline for our postprandial, looking at those biomarker frequencies, amplitude, rhythm index, etc. And we had 36 patients, and we had 9 that were pre and post temporary stimulator. And when they got their temporary stimulator, they did much better, as people that have had it know. We showed no changes in the baseline metrics overall, but when we looked at the 9 patients, the rhythm index, which is a frequency measure, and the BMI adjusted amplitude, which is an amplitude measure, predicted who was going to respond. So we'll have to see as we get larger numbers if that's true, but it may be possible that we can predict who's an interim analysis may predict responders with frequency and amplitude measures. So we're recruiting patients for this here in Louisville and elsewhere. Actually, the other part of our study is in Temple in Philadelphia. Some of you have been there as well. So let me go on next to, I've talked about temporary and permanent stimulation. We'll talk about dysfunction. Pyloric dysfunction has been known for many years. Some of the original work was done when I was a fellow, not by me, but some of my colleagues. Pyloric trials have been sort of mixed. Sometimes it seems to help, sometimes it doesn't. G-PACT, where third space endoscopy disrupts the pyloric sphincter, is now actively studied in double-blind randomized controls, has an improvement, probably 60 to 70%, similar to the same percent improvement that you get with stimulation. But the question is, who can be helped? And one thing we've used is FLIP, which I'm going to talk about, pyloric FLIP. It measures, if you're not familiar with it, basically distension of a sphincter. We look at the diameter and other measures. And people have used botulinum toxin for patients with abnormal pyloric compliance for many years. We wanted to see if patients that had prior interventions, in other words, many have had stimulators and other therapies, had long-term benefit from pyloric FLIP. So we looked at 61 patients, and when FLIP, Botox was administered, and if the disability was low, 10 is the standard cutoff, 10 in those units. And then we looked at the FLIP metrics. Again, we have metrics sort of like we have gastric emptying and metrics, and we have metrics for high resolution EGG. We have FLIP metrics. And we wanted to see if it was different between people who improved and who didn't improve. We used standard statistical measures. Our results with 40 people with abnormal DI and FLIP, but 40% reported symptom improvement, and those people had higher pyloric diameters. Patients with the improved group had more normal mucosal EGG amplitude, which we also measured, and lower frequency amplitude ratios. Those are frequency and amplitude, 2 of our other metrics. And we also found some other trends that were significant. Otherwise, there were no differences in baseline follow-up gastric emptying time. So we concluded that patients who've had previous work done went to FLIP and Botox. Those with higher pyloric diameters showed the most improvement. And patients who improved to Botox had normal gastric physiology at baseline. So further profiling might be helpful for who should get G-PACT. There's also a trial that we just started here, and it's been going on elsewhere, looking at body surface mapping, high resolution EGG, and G-PACT. So we're going to measure people G-PACT at baseline, symptom diaries, then 1, 3, and 6 months, with the option of repeating the body surface mapping. And that's just starting, and we hopefully enroll our first patient this month in July. So what I'd like to talk about is the third thing I've talked about, stimulation. I've talked about pyloric therapies, and I want to talk about immunotherapy, and this is on IVIG. And IVIG, which is intravenous immunoglobulin, which is a mixture of many immunotherapies that are mixed together and given to patients. It's used and approved for a whole bunch of neurological disorders. It's off-label for this. But we wanted to look at people who are getting it because we've done nearly hundreds of patients with this, between gastroparesis and functional dyspepsia. And we had close to 100 patients, 93, 66 for gastroparesis, and 27 functional dyspepsia. And we gave a 12-week course of IVIG. It's weight-based once a week, requires an IV to get it. So we wanted to look at how people did after 1 week, one 12-week course, excuse me, and then long-term. And then we looked at 1 point increase, which is standard on the 5-point scale, or a 25% decrease in symptom score. And we compared it statistically. So results, basically, mostly Caucasian, mostly females. There were no significant difference in both groups between the two. And overall, there's about a 40% improvement, which other groups, including Johns Hopkins and Mayo, have reported about 40% improvement with IVIG. We found very similar between functional dyspepsia and gastroparesis, roughly 40%. And some would say, well, 40% is not very great, but these are people that basically have failed everything. They failed drugs, they failed diet, they failed devices. In most cases, they failed pelvic therapies. So I'll show just a couple of examples here. Here's non-improved versus improved. Here's the gastroparesis. I'm going to look at the improved group here in this color and non-improved. But interestingly, some people improve at 12 weeks and then continue to improve. Others improve at 12 weeks and then plateau. So it depends what the symptoms are. Pain, it's interesting, and reflux continue to improve. And if we look at the functional dyspepsia, you see the same thing, although vomiting for that group continues to improve. Nausea continues to improve. Pain, sort of plateau, reflux continues to improve. So for the people that get this, they really feel a lot better. So it's an ongoing open label trial. We've not been able to get funding to do that because it's very expensive drug, funding to do a double-blind randomized study, which we need. But in patients with both gastroparesis and functional dyspepsia saw improvement. And further studies we'd like to do. So I'm gonna, I've only taken about half an hour, which is good because it leaves a lot of time for questions, but let me make a summary for a minute. Gastroparetic symptoms aren't rare. We know it's at least 1.6% of the population have gastroparesis. And in some areas like Kentuckiana, where we are, it's probably close to 3%. So it means we have 1 million people in the Louisville area, for example, and we see only 5% of those people that may have symptoms. And the symptoms themselves may be common. Either the NIH PROMISE study said about 9.5% of the population has nausea, vomiting at some point. So we've got some new tests, and there are more on the way. Got some new treatments. Drugs and devices are available, although we'd like more drugs, we'd like more devices. Disruption detoxification may help. The question there, if you talk to anybody who does it, is find the right patient. Who's the right patient for those? Diet's always important. I hope with the new emphasis in the administration on diet, I'm hopeful we're going to all learn a lot about diet because it's been a neglected area. And then hope and support. I like to mention hope because there are a lot of people, a lot of my colleagues working on this. I'm in my 70s. I've been working on this since I was in college. So I've been working on this for decades. And I have colleagues who are equally dedicated in terms of their careers. So a couple more things. I'd like to thank our funding agencies without which I wouldn't be able to work. Our regulatory agencies that are friends, even though they may not seem like it. The drug and device manufacturers, our hospitals and clinics and staff, providers and colleagues, support groups, and especially the patients and their families, which is what we do this for, is the patients and their families. So I'm open to any questions. Hopefully we have enough time, we'll be able to cover most of them. And if not, I'll work with G-PACT, and I'll always try to respond to every question that I get.
I've got some questions in the chat, Dr. Abell. Do you want me to read them to you?
Sure, and I'll stop sharing this too.
Okay. So the first one is domperidone likely to get FDA approved anytime soon?
Well, I don't think I was the person that presented the DUM5 trial for approval, and I don't know if you're aware of this. The FDA Advisory Council unanimously recommended domperidone be approved. The FDA leadership denied the request for political reasons. Those people are no longer there, but So it wasn't approved initially. I don't think it's going to be approved now because it's off-label. Now there may be some domperidone. I mean, it's out of patent. There may be some. I mean to say there may be some domperidone-like drugs that get approved, and we hope so. We also hope very much that the FDA allows us to find a supplier, and people that have been getting it on the compassionate need program can continue to. Otherwise, it's going to be real hard for those patients. I hope I answered that correctly for you.
Okay. The next says, when contacting our congressman asking for help to get the FDA to approve domperidone, how can we convince them that there is a growing number of patients that need this medication? Do you have any numbers of the increase in GP patients that could benefit from this drug?
Well, I don't know that I do, but I think between the support groups and plural, I think we can come up with those numbers. And I might get in trouble with the politicians for saying calling a politician, but the way I look at it, we're all voters. All of us are voters. And if we're having trouble getting, I've gotten great help sometimes when I call politicians for, I've had a visiting professor wanted to come and couldn't get a visa, and they helped me out in all kinds of ways. I think the big thing would to say that this FDA program is being shut down, and we have, all of us, patients, physicians, providers, we would all like this program to continue. It's been there for 20 years, and the drug is still available widely around the world. I don't personally see why it can't be available more widely again in the U.S. I don't know if that's helpful, but it's kind of what I would say.
I'll go the next one. We have, what can be done when you are highly sensitive to mostly all the drugs? I was told that I can't get the stimulator because of my gastric bypass. I'm very serotonin sensitive.
Well, it's a couple of questions about sensitivity, one of which I'll talk about in a minute. The other thing in terms of neuromodulation devices, it's off-label, but it's been used widely in people post-bariatric surgery, and that's been published by us and lots of other people. So it's not a contraindication, but we recommend usually trying a temporary at first to make sure it's going to work. But in terms of sensitivity, serotonin is crucial. It's one of the main neurotransmitters. It's primarily in the body and the gut, and that's why serotonin drugs work so well. I'm not sure what serotonin sensitivity means. And it may not be your case, but for some people are very sensitive to lots of drugs. I remember I used to kind of grown medical school residency when I'd see these people with these long lists of allergies. What I didn't know is that many of those people have a cytochrome P450 abnormality. Those are the enzymes that metabolize drugs. And those are widely known now under what's called pharmacogenetics. You can get pharmacogenetic testing to see what things you can tolerate, can't tolerate. And so I order it all the time. Mayo and Quest, Mayo Medical Labs and Quest both offer pharmacogenetic testing. The most common one's 2D6, because most drugs are defined by 2D6. But for people that have trouble with PPIs, the 2C9, 2C19 may often be abnormal. Some people are rapid metabolizers, so they require a lot of a PPI. And people say, no, you couldn't possibly need that much PPI. Well, you can if you're metabolizing it rapidly. So that may not apply to you, but for anybody that has a long list of drug allergies, I would definitely get pharmacogenetic testing, which is standard Medicare. I don't know if Medicare pays for it or not, but it's standard approved testing. Hope that's of some help.
Okay. The next question says, since gastroparesis symptoms vary for some as frequently as day to day, does that suggest that the stomach is experiencing increased motility on some days while experiencing decreased on others? If so, how is that taken into consideration during testing phases, considering testing may occur on a better day?
Yeah, great question. You're absolutely right. Patients vary a lot. Some people have distinct cycles, distinct symptoms. They'll tell you, like, I'm sick for a week, and I'm better for a week. And they can even pinpoint when it gets kind of kind of frightening when they say, it's the 18th, I'm going to be sick. How could that be? Well, that's been looked into quite a bit. And some of that is probably genetic, actually. The cyclic vomiting people, which is a different disorder, cyclic vomiting, but cyclic vomiting people have looked into the genetics of that, and there are different genetic profiles. Also, we know that, for example, people with diabetes and diabetic gastroparesis oftentimes have cycles. And over half those patients with diabetic gastroparesis have cycles where they're better for a while, worse for a while. And it can be it can be one day or another, or bad for 2 days and good for a day. And you're absolutely right. It can make a difference in terms of testing. That's why we, like with our temporary stimulator, we do it for a week. And we oftentimes for symptom diaries do them for 2 weeks or longer, because we want to get those patterns in effect. And it's kind of like I'm a car guy. When I take my car and it's making noise at home, I take it in there and it's not making noise. It always happens. And then they say, well, I don't know, I can't fix it because it's not making any noise. But just kidding. The mechanics are my friends. I'm an old car guy. It's like that with symptoms. And so hopefully your providers are aware of that, make them aware of that it might not be a good day. Now, interestingly, we're very interested in that with things like the body surface mapping. When people are having cycles of symptoms, does that change or not? We don't have the answer to that, but we're trying to look at that. So hopefully we'll be able to get some answers, because it's possible that I did a study at Mayo Clinic when I was there, looking at people with cyclic vomiting, and they had abnormalities of their motility even when they weren't vomiting. So they have some underlying abnormalities. Anyway, long answer, probably for a good question.
The next question says, is dizziness a common symptom? As my GP doctor said it isn't, but I'm very dizzy.
Well, in my practice, it's very common. I'll tell you for 2 reasons. Half of our patients with gastroparesis in general have migraine, and I'm not a neurologist, although I almost went into neurology. I interviewed for neurology. I just didn't do it. But I'm a neurogastroenterologist, and so half our patients have migraine. So I know our migraine expert really well. And one of the hallmarks of migraine actually is dizziness when you stand up. If you talk to migraine patients, they'll say, well, doesn't everybody hold onto a chair when they stand up? Well, not everybody does, but most people with migraine do, because they have orthostatic hypotension. It's a marker. And also it's seen in dyspepsia. So dizziness is very common in my experience.
Okay, the next question says, is there a flow chart to go by with who can benefit from the pylori flip, G-POM, and Botox? I've never been offered any of these. Does a regular GI do it, or a specific surgeon? They also said, I have heard of all, but no one at my clinic ever mentions these. I started with diet changes, then gastric stimulator, J-tube to GJ to G, and then G-tube plus TPN.
Great question. I'm sorry I've been through all that. Not that we would have done anything differently, but in terms of pyloric therapy, I don't think there's yet flow sheets, but there's tremendous interest. Most of the G-POMs are done by interventional endoscopists that are trained in what's called third space endoscopy. But every medical center has an interventional endoscopist. Not every medical center does G-POM. Some cities, I know, I've had friends who are G-POM experts that moved into major cities that remain unnamed, and they find that they're the only person doing G-POM in the city of 8 million people or something, which may give that city away. But not everybody does it, but it's anybody can do it that's trained in that. So and it really helps. For some people, it's wonderful therapy. So is Flip going to predict that or not? I don't know, but we're presenting at ANMS in a couple of weeks. We're going to have that written up and presented for publication, hopefully this year. I would hope within a year or two there'll be some flow sheets. Also, we're doing this study with high resolution manometry and G-PACT that again the goal would be to have a test to predict, yeah, you're likely to benefit before you undergo something. I will also mention to toot our own horn, we have an article that's in press in neuromodulation on with and without J tubes for gastric stimulators. It's got 200 people, 200 or 300 people in the study. So that's not out yet, but it'll be out in the next month or so, probably.
Okay. Our next question says, regarding IVIG due to cardiac arrhythmia, which is currently not controlled well, my cardiologist will not clear me to move forth with IVIG at this time. Can you explain why he is discouraging IVIG? He has not explained it clearly to me.
Well, I don't know. Of course, I wouldn't want to interfere with cardiologists may have accident reasons, and I don't know your cardiac history. One compromise might be to see if you can see an autonomic neurologist, because the autonomic neurologists, or neuromuscular neurologists, are all trained in IVIG, and they can do autonomic testing and see if they think it would benefit. And that's when we have questions. That's what got us started on this. Was the neuromuscular neurologists use IVIG all the time, and they do autonomic testing, and they work closely with cardiologists as a group. I'm involved with, or have been over the years, with the American Autonomic Society. That's deals greatly with disorders like POTS, and the cardiologists are a big part of that. So hopefully you can find somebody to give you another opinion on that.
Okay. The next question is low-dose naltrexone being explored for the treatment of gastroparesis?
There's been some work done on it. It's been attractive, and there's been some case reports. I don't know if there's a trial right now going on. If you want to know, you could look on clinicaltrials.gov. Just search. You can search for that. We have all our trials basically in what we call CTG, and I don't know the answer to that, but it's kind of intriguing.
The next question says, my friend has gastroparesis and weight gain and swelling on domperidone in Canada. What things can she do to help with swelling and weight gain? And do gainers eventually lose weight? And why would they lose weight?
Well, it's a great question. We did a double-blind randomized study, metoclopramide versus domperidone, a number of years ago, and some people do have some swelling issues. What we say in medicine is we individualize it. We just see an individual patient and see what can be done. Without knowing more, I can't say, but it would be worth having it explored and seeing what the options are. In terms of weight gain, it's a huge problem. I used to see 30 years ago patients who were all thin with gastroparesis. Now, a few people are thin, but hardly anybody is. Most everybody is dimensions is overweight or obese. And I think that's because of the dietary regimens that we have are largely carbohydrate based, because that's what people can tolerate. So hopefully on any given patient, they can get feeling better and then eat a more balanced diet and lose weight that way. I'm also hopeful we're going to learn a lot from the GLP, GIP drugs that'll help us manage gastroparesis better. But I don't think we're quite there yet.
The next says, have you seen success with G-PACT for nausea? I had the battery replaced in my stimulator this year and have had success in decrease in vomiting, but nausea has increased.
Well, we do see improvement in nausea as well as vomiting with G-PACT. And whether that would be the answer for you, I don't know, but maybe with, again, something like a flip might be a helpful test to see if you have pulmonary spasm or not. In which case, if you do, they may or may inject Botox, see if you respond. Not everybody that does G-PACT believes in that, but it's been what we're currently looking at, and we're also looking at that for the National Institute of Health, one of our current studies. So there'll be some control data on that pretty soon. Well, I certainly hope you get feeling better.
Okay, this one has a medication. I'm going to butcher the name of, of how to pronounce it, but it says my daughter has taken cyproheptazine for 2 years, but is starting not to help. What can her next option be? She's 14 years old. Any probiotics or multivitamins could help.
Sure, cyperheptadine
Thank
is
you.
oftentimes used in younger patients, particularly for dyspepsia or cyclic vomiting. There's a whole bunch of other varieties of meds that can be tried. And again, I would individualize, just have the provider try to look at the best other options. But the other thing is, depending on the weight, may need a different dose, because people grow and get bigger and may sometimes need a different dose. But again, I can't make an individual decision because I don't know the details. But it should be treatable. And the pediatric group, I'm primarily adult gastroenterologist, but I also train in pediatrics. So the NAPS-GAN, which you can't say very well, North American Pediatric Group, is very interested in this, and they'll have their meeting this fall.
Okay. The next says, I am the caregiver for my son who has intellectual delays, epilepsy, several other challenges. He has symptoms of GP and has had a few endoscopies, which made him highly suspect for GP. He's currently on Motegrity and Prilosec, but he can't tolerate tests like the gastric emptying. Are there any facilities who regularly deal with the special needs population? I'm familiar with many special needs folks who are suffering from various GI issues, but sadly, we're finding there is a shrug the shoulders attitude toward our loved ones. What would you suggest?
Well, that's a particular interest of mine. I for almost 10 years, long story, for the state of Tennessee and the Department of Justice, I worked with in a hospital for severely disabled kids that had to be hospitalized, and they had so many GI problems that the government got involved. And I worked on that and published that data, actually. That was 20, 30 years ago. But so I know how difficult it is, and I have a particular interest in that. But one thing that might be helpful for someone like him would be these high resolution manometry, because that's, if they can tolerate something on the abdomen, that can be measured without having to do gastric emptying and things. And that, I don't know where you're located, but it's approved for ages 12 and older. CHOP, Children's Hospital of Philadelphia, has a program, actually a research program going on for that. I don't want to inundate CHOP with calls, but they do have a program going on that they're presenting their data in a couple of weeks at the meeting, and I know them well. So it's based on their data that probably it's going to be approved for people less than 12. So that would be an option. I certainly regret the difficulty people with special needs have getting care. As a former primary care doctor myself, I think that's unfortunate, but it's the reality. But hopefully the support groups could be helpful. And I don't know if there's a support group. I know there's one for migraine that I've been active in. I don't know if there's support group, what the support groups are like for disabilities. My wife's a retired child psychiatrist, so she used to see some of these kids and probably is aware of some of the national groups. But if any of them have questions, I'd be happy to try to answer them.
Next question says, I have had 8 stimulator battery changes since 2016. Are the batteries becoming better or possibly becoming rechargeable?
Well, good question. I can speak a little bit to that just because I'm on the research side without the Intermolecular that makes that device has a couple of studies going on looking at ways to prolong battery life. Those are studies are already over a year old that I know of. So I know they're interested in that. I know I can't speak for them. The technology to make things rechargeable exists in the world. I don't know where it is in their priorities. But hopefully out of these trials there'll become ways to prolong battery life. Yeah.
Okay. The next says, I've had success with Motegrity, but have had issues with having to fight to get it approved by Medicaid every year when they change their formulary. I get to where I can hardly eat solid food without it. It seems to be the only medication available that helps me. Are there other medications approved in the US for gastroparesis? I have colonic inertia as well and have been on a lot of the medications like Amitiza without success.
So precaliprate integrity is one. I've got a couple stories about that, how it was developed. But it's one of my favorite drugs because it improves not only constipation, but it improves the stomach. And it's a 5-HT4 agonist. It's the only one we have. Unfortunately, we don't have any other 5-HT3 antagonists, 5-HT4 agonists available right now. I'm extremely familiar with battling over that and getting approval by formularies. And usually, if you document that you've tried the other things for constipation, if this is the only thing that works, they'll approve it. But I know I'm on the phone a lot for that reason. But it's good. It was developed by originally by Janssen J&J, by a guy named Jan Scherkes, who I knew in Belgium, and he thought it was a great drug, and it is a great drug. Finally, it's available. It was available in Europe for a long time before it was available in the U.S. And so it's one of the good things that's happened with the FDA is getting that drug available, and hope you can continue to get it.
The next question says, is it normal not to have vomiting or diarrhea with GP?
Is it normal not to have? Well, vomiting varies a lot. It depends on the person whether they vomit or not. The most common thing, it's 90% of people have nausea. Diarrhea also is variable. I think constipation is more common, but some people nothing but diarrhea, and some people have. We see the combination of nausea and diarrhea, for example. But any mixture of any things can be. Later I'll tell you a story about that. But there's no one size fits all.
The next says, just wanted to say that I've had GP motility issues since I was 14 years old following a virus. I'm now 67. Initially had surgery for SMAS followed by a FINI pyloroplasty and did very well for 28 years. When symptoms returned in 2001, I felt worse than ever and saw top motility doctors in Philadelphia. I tried everything to no avail. For 13 years, I had constant nausea, constipation, etc., and only recovered when placed on 3 psychotropic drugs for depression. I've been totally well now for 11 years and talked to medical students here in London, UK, about my journey. Just wanted to sing the praises of pyloric surgery and the use of olanzapine and other drugs for improved GI motility, including constipation that plagued me for 13 years. I eat normally, suffer no nausea, and move bowels daily. I'm glad to talk to others about my experiences. Thank you for sharing that, Caroline. Um, the question that follows that says, is there a relationship between pelvic symptoms, for example, prolapse, tight muscles, etc., and gastroparesis?
I don't know if there's a direct relation, although there was an article. There was an article about pathophysiology that it came out this week in neurogastroenterology motility from France, from Rouen, ROUN in France. Uh, I certainly pelvic floor dysfunction in general is not uncommon in gastroparesis. Because of my background as a primary care doctor, I did OB and I did peds. And so I'm part of the urogynecology fellowship here. And we see people that have both conditions pretty often. I'd have to talk to my colleagues about which pelvic floor, the pelvic issues are more common, but it's the same nerve and same muscle and same innervation. So it's not surprising they're similar. And we have a fair number of people actually over the years that have both gastric stimulators and sacral stimulators. We've published that. But there's renewed interest in that. So I'm glad you asked that question.
The next question says, is age a factor in what treatments are available?
Well, there certainly are in terms of approvals. A lot of things are approved for people less than 18. So it becomes off-label and then becomes harder to get. I don't think that age otherwise makes a difference, but in terms of ability to get approved drugs and sometimes get insurance to improve it, it can be an issue, unfortunately.
We have my GP has been under control by diet. The biggest problem is that I have 3 to 5 bowel movements every morning. I add as much soluble fiber as I can to my diet and take Miralax every night. Do you have any suggestions for more complete bowel movements?
Well, that's a difficult question. Great question, but difficult to answer easily. I'm glad your GP symptoms are better. I guess the one question is whether a given bowel movement feels complete or not. We call it complete evacuation or incomplete evacuation. Because if you're having incomplete evacuation, it implies a pelvic floor disorder that needs to be looked at. If it's a complete evacuation, that is unusual, but not impossible, not unheard of. Other than fiber, I don't have any other great ideas. Probiotics might be helpful if you're not already taking. Cultural is the one I use the most, but there are lots of good probiotics.
We've got 2 more questions. This one says, my daughter is 2 and has gastroparesis. She has been experiencing severe gas, especially when she wakes up and right before bed. We vent through her G-tube frequently and have tried feral bags. Is there something else we could do? And is excessive gas a common symptom of gastroparesis?
Well, it can be. It's a little harder too. If you have a G tube, this would be extreme, but it does offer the ability of trying neuromodulation temporarily through the G tube, which some of the children's hospitals do, and we've done. The youngest patient we've done this too. But I'm not saying they need that. But an evaluation of transit might be helpful. I don't know how young the new Atmel pill, it's smaller than the smart pill. I don't know how young that could be done, and don't think it's approved for children. So maybe hard at that age. I would certainly see what the pediatric gastroenterologists think, because it gets a little easier to evaluate as they get a little bit older. But the peds GI people are pretty skilled at things they can do for gas, so I would sort of talk with them.
Okay. Looks like the person who wrote about their son with intellectual delays said that they're in Illinois, but will go and have gone all over for help and mentioned where in Philadelphia.
Oh, CHOP is Children's Hospital of Philadelphia.
Okay. And then we have my insurance does not do gastric stimulator, and I'm having difficulty getting another hospital to accept my referral. I turned 65 in 7 months, so time is of the essence. Do you have any suggestions?
Well, not to put off anything 7 months, but you presumably have Medicare at age 65, and Medicare covers the stimulator, so that might be an option. I'm so sorry to hear that. We and other centers don't see anybody, although the wait sometimes is kind of long. But that was one thought, being that close to Medicare age.
The next question says, is it common to have GERD symptoms with GP?
Yeah, extremely common.
Okay. Then it looks like a comment. I'm not sure if there's a question attached to this one, but it says I had heart stent surgery in February. 3 weeks later, I got GP. Oh, could the surgery be to blame? I'm 75.
I don't know that it's to blame, but there's association between cardiac dysfunction and gastric dysfunction. That's well-known association. And so they can come on together, and cardiologists and gastroenterologists both aware of that.
Okay. The person talking about the stimulator said that they were told Medicare won't cover the stimulator.
Well, it's covered it since 1995. Yeah, covered with that. As soon as it became investigational, it was covered. Yeah, let me know if there's a problem with that. We can contact Interior Medical, though. They can help them with that.
Yeah, I was going to say if there is an issue with that, G-PACT has a very good relationship with Intera Medical, so you can reach out to us anytime as well and try to get you in the right, to the right person. Um, we have one last question just popped in that says, have you seen any patients with developing GP, autonomic dysfunction, mast cell, etc., following the Gardasil vaccine? That is the cause and start of my illnesses.
I haven't, but I haven't, but I'm not that familiar with the vaccines. But any vaccine has potential for problems, particularly if someone was prone to it. Yeah, sorry to hear that.
Well, that was the last question in the chat. I can say to everybody that if you do have any additional questions, you can feel free to reach out to us. My email should be on your invite for the webinar. And if you have questions for Dr. Abel, Dr. Abel, I can send you any questions that come in and we can try to get them answered for everyone. But
I wanted to say one thing, Sam. We're totally out of this, but I gave a talk recently at the International Veterinary Meeting. I didn't realize, because I've used animal models, I didn't realize that dogs and cats particularly have tremendous problems with gastroparesis. And the veterinarians are very interested and do some very unique things. So I just wanted to mention it's not just humans that have this. We have some of our animal friends have the same problems, which was news to me.
thank you so much, Dr. Abel, for this. I know I've learned a lot as usual from you. And thank you everyone for coming today. Like I said, if you ever have any questions, reach out to us anytime and we will do what we can to get your questions answered. So,
Okay, great. Good. Thanks for joining.
Thank you.
Okay. Bye-bye.